All right, perfect. We are now live on Facebook. I'm going to send a message in the chat real quick so that everyone can see the little notification. If you have any questions throughout the webinar, this is where you'll send them. And then when we get to our FAQ, I can most likely read them off. And we are now going to be getting started.
Hi, I'm Dr. Angela Yakey.
And I'm Dr. Kathleen O'Neill Smith.
Welcome back to the FIRRIMup Doctors, Good Medicine docu-series.
We are so glad you joined us.
We want to provide you with credible health resources, guide you in your treatment options, and fire you up to take control of your health.
Dr. Akey and Dr. O'Neill Smith have done an outstanding job of clarifying the main concerns during this coronavirus pandemic, as well as giving clear guidance on how to empower our immune system to best protect ourselves and those we love. This is a resource everyone needs right now to listen to and follow. I'm Dr. Anna Kabeka, gynecologist and women's health expert and best-selling author of The Hormone Fix and Keto Green 16.
All right, this is once again our guidebook, Kick COVID-19 to the Curb, which is available on our website, FIRRIMupDoctors.com. The little excerpt you just heard was from Dr. Anna Kabeka. Her picture is right here. She was one of Dr. Kathleen and one of Dr. Akey's close friends and a best-selling author of Keto Green 16. That little excerpt was a review she gave on our book. And we are happy to finally say that our ebook is now available on Google Play. If you go back to our website, FIRRIMUPDoctors.com, you will have the link on the very home screen and it will lead you directly to where you can purchase it. And now, without further ado, I'd love to welcome your FIRRIMup doctors, Dr. Angela Akey and Dr. Kathleen O'Neill Smith.
Hi, everybody. Thank you, Emily. That was a great introduction. Hi, Dr. Kathleen.
Hi, how are you, Dr. Akey?
Doing great. Thanks, everybody, for coming. If you're in Gainesville or the North Florida area, this is our 13th week together. And yeah, there's been a little uptick in the amount of cases, at least in North Florida, Dr. Kathleen.
I know, it's amazing. I just think back to colleagues of ours who texted me early on because they hadn't seen any cases in their states, like Idaho and Texas and different places. And they said, is this real? And of course, in the Northeast, we were seeing lots of cases.
Yeah.
Here. And now I know that Texas and Florida and Utah and California are having upticks. So, you know, when that was happening in conversation, multiple doctors knew that it would be spreading. It was just a matter of time. So it does warrant that we really do take care of ourselves. And I think you can see from this graph, this countrywide view, that southeastern Florida has been hit a lot harder than where you are.
Yeah, I think like South Florida, Miami and Fort Lauderdale, they had a lot of travelers early. Southeastern Florida is now, and now North Central Florida. Next slide, please. We can actually see some statistics, at least in Gainesville, that last week we had reported 392 cases confirmed in our county, Alachua County, but now we're at 443 confirmed cases. And so we are going up. So from going back to the United States, we hit the 2 million mark over the past week. Deaths were, go ahead, back to the statistics, Emily. It was fine. Deaths are 113,000, 500,000 recovered, total tested 21 million. In Florida, about 1.3 million test results confirmed were 61,488. hospitalized 11,621 and recovered over 500,000. Deaths are 2,712. But in our county, again, we've had an increase from 392 last week to 443 this week. There have been 8 deaths. And then in our community at North Florida Integrative Medicine, we've had a total of 75 serology tests over the past 3 to 4 weeks, of which 3 have been positive. 2 were IgG positive from patients that have had COVID. At least we recognize patient 0 as having had COVID after the fact. And then the healthcare professional patient number 4. Today we had a point of care IgM positive, which we're going to talk about in a little bit. So that's the scope here in North Central Florida. Our cases are going up.
I think really, the point on this slide, the really key thing to notice on this slide is not the total confirmed cases at this point, because we're not anywhere close to herd immunity nationwide or county-wide or statewide. I think the reality of what we want to understand is who's hospitalized and how many deaths, because the goal is ultimately to reduce hospitalization and to reduce fatality deaths. So that's really what we want to understand. I think that the data on the testing is a little confusing and the confirmation, because we don't really know what that signifies. We don't know if it's multiple people who have had 4 nasal swabs. I think that there's no, Dr. Akey is an expert at standard operating procedures, SOP, let's go. And she's meticulous about creating SOPs. And I think that within any state, Florida, Massachusetts, and certain globally, there are no standard SOPs. So I think those numbers can be confusing. Regardless, I think it demonstrates that there have been a lot of tests that have been performed. There's a lot of people who have tested positive in one way or another. We're not sure which. And there are a lot of people who have recovered. The question we really want to know is how many hospital beds do we need? Because if we have more people needing to go in the hospital than there are beds, we are in trouble because people will get sick. And the goal is keeping enough hospital beds available so that we can get people in who need to be in the hospital and helping them recover. That's always the goal, right? So
I think we've done a pretty good job of that, at least in North Central Florida, because our seroprevalence is still like 5%. And within our community, the 6,000 patients here at North Florida Integrative Medicine, our seroprevalence is less than 1%. And so
what do you mean by seroprevalence, Dr. Akey?
So what I was saying was if we had over 6,000 patients and if we were trying to obtain herd immunity, you'd need 3,600 patients having positive IgGs. And so we don't have the resources to check everyone's IgGs, but at least in the samplings that we've done in the office, we've done serology testings of which only 3 have any positivity. So at least as far as I can assess from our community, that there hasn't been a lot of penetration and everyone's had the hotline for the entire 3 months.
Right. In our community, in my community here in Boston, I have probably close to 25 who are seropositive, but none of them have been hospitalized. All of them have recovered at home, only using our immune boosting type of supplements because we do that in our practice naturally. All of my patients, they wouldn't come see me unless they wanted me to make them well because I treat wellness. It's the name of my practice. And so all of them have had fevers and maybe lack of smell or lack of taste. And they all have had been able to stay home and only taken Tylenol in some cases, and other cases, nothing. So, and they've all recovered within 10 days. So during that 10-day window, they stayed home and then they all developed antibodies. So I think that's pretty cool because now they are likely to have herd immunity. They have immunity. They are not going to infect other people and they are not going to become infected, which is pretty cool for them. Thank goodness.
So what you're saying is that at least in your patient population, you've fortified their castle coming into it. And I think with our seroprevalence rate within our community at North Florida Integrated Medicine, we've done the same. And so that when they do get sick, they don't become terribly sick.
Correct. They don't need hospital. That's the goal because we're all going to be exposed and we need to get to the other side of it with the least amount of problems, whether they're health problems or any other problems. So that's the goal. So the goal is to have as much time as you can to build immunity, because when you are exposed, and you will be exposed at some point, you will be exposed. Hopefully either the virus isn't virulent, but that's going to be a long time, or you've got a really strong immune system so you can readily handle the virus.
Exactly. You're fortified.
Yeah, exactly.
So how are you doing in Massachusetts?
So we're doing well. I mean, we look at curves in terms of, are the curves going, where are you on the curve? Are you still going up? Are you on the plateau? Are you on the downside? And we base that here on the number of beds available. And so the largest hospital in Boston has 1,000 beds. And we have a lot of empty beds right now. We're not at full capacity. And we were at full capacity with all beds filled by COVID patients. So now we have we have a lot of capacity to do elective surgeries, to have people come to the hospital, the office for whatever they need. If they need an MRI, if they need a particular test in the hospital, they can all go. So there's lots of precautions. We are very, very strict here about precautions. We're in phase 2A. There's phase 1, phase 2A, then there'll be phase 2 in another week or so. We do each phase for 10 days to see whether or not we get an uptick in our number of cases, but we haven't had an uptick yet. So we're just continuing to follow that. But, really people are not out and about yet. People are not out. The restaurants are at 25% capacity maximum, and it's all outdoor. So it's pretty interesting. We're very rigid here.
And that's why you have it under control?
Hopefully. I mean, hopefully that will last, but we'll just have to wait and see. We're still learning new things about this virus, and that's why we're doing these webinars weekly so that we can keep people updated.
Okay. So we need to, today we wanted to talk about a Kick COVID to the Curb frequently asked question number 11. So you're in phase 2A in Boston, and we're in phase 2 in Gainesville in North Central Florida. I've been doing consults all week on this question: is it safe for me to go back to work? And so there were 2 papers that we pulled. The first one was from the Annals of Internal Medicine on June 3rd that said that the first point, that asymptomatic COVID infection suggests that 40 to 45% of those infected with COVID-19 are asymptomatic, meaning no symptoms, and may be able to spread the virus to others for over 14 days. So silent transmission. And that's the first point we wanted to make as we discuss a table that we adapted from the next article from the New England Journal of Medicine. It was a point of view of an author. And so this is a fun table, and we could go through examples. But basically, to orient you, on the x-axis, we put the risk of death from COVID-19, and your low risk if you're less than 40 with no high-risk conditions like heart disease or arrhythmias or autoimmune or anything like that. Your medium risk if you're middle age, or you're younger, like some of my 20-year-olds who actually are working from home because they have ulcerative colitis, for example. We would put them at the medium risk. And then at high risk is if you're over 65 with those comorbid conditions we keep talking about: hypertension, diabetes, asthma, chronic kidney disease. Or if you're middle-aged, like 40 years old with a high-risk condition, you're at the high risk of death from COVID-19. So that's the x-axis. Now this is where we get into the work issues. On the y-axis, you have occupational risk of COVID-19, meaning if you're in the workplace, would you be exposed? So you have low risk, which are strict physical distancing situations, or telecommuting, which means working from home, like when we're doing telehealth when I'm doing my consults. Okay, that's a low risk of occupational exposure for me as your doctor. However, when I'm back in my office, it's high risk because it's exposure to people who may have COVID-19. The medium risk people are uncertain COVID-19 status. So that would be like the checkout girl at Publix. Like she's seeing the public at Publix. And so she would have medium occupational risk. So the grid's pretty easy. The grid is pretty easy, where what we're trying to do is we're going to try to mobilize the people in the green, and then which are on low risk. At this point, these are the 20-year-old people who actually are working in our office. We have a bunch of interns who are 20 and healthy. We have 2 that have autoimmune disease that are at medium risk, are working virtually, and they're in the yellow, okay? And then our population that I've always considered high risk are the chronic care management Medicare patients who we've outreached to since March 15th to continue to have you shelter at home. And we touch base with you at least every month, and you've been coming to our fortifying your immune system group medical visits. So the high risk is the red area. And so when you look at this grid, it really helps us to make recommendations with you individually. If you are at low risk, i.e. the young 20-year-olds, the suggestion is to go ahead and mobilize into the community to serve the community. Follow CDC guidelines for facial covering, hand washing, and physically distance. If you're medium risk, i.e. the yellow, these are individual telehealth conferences regarding risk of going back to work, options to limit exposure, and consider stopping work. Take all precautions mentioned in the low risk population, which is facial covering, hand washing, and physical distancing. So I just got off the phone 2 days ago, and the patient's fine with me telling you this, but basically 2 days ago, an office worker who is 64, almost 65, planning on retiring in the fall, who has asthma, who actually, she was asked to go back to the workplace, but her job is to meet the public, and she's the administrative assistant. And so we went through the risk benefit ratio. She's in the yellow range. And so I took the time to fill out the 5 pages so that I'm recommending that she work from home due to her chronic condition. So this is a very real conversation that we're having every day with our individual patients. What about you, Dr. Kathleen? Are you having these kinds of conversations in Boston?
Yeah, of course. And then, I also am working with some companies who have large numbers of employees around the country, one with 500 employees. And the reality is this. Well, first, I want to say that the most important thing to understand about COVID-19 is that it requires human-to-human transition predominantly. So that's important. It needs a host to live generally, but if the host is spewing live sputum in places, which is why 6 feet is good, but 9 feet is better in terms of physical distancing. The bigger the physical distancing, the better. But the reality is it requires a host, and the host that's going to be most susceptible is a host who has any type of disease of their blood vessels. So if they have any inflammation, if they have any blood sugar abnormalities, if they have excessive weight, if they eat a classic Western diet with French fries and processed foods, they are inflamed. Their inflammasome is activated. So that's pretty important. If somebody has high blood pressure, if somebody has cardiovascular disease, if you have any vascular disease, blood vessel disease, if you have inflammation at baseline, then you're going to be at high risk. So those are the primary high risk people. But the reality is that in Boston, anybody who can work from home should work from home. Anybody who can work from home should work from home. If we could then slowly reintroduce the low risk people into the community, and we've talked about this last week as well, and keep the vulnerable people. Age is not the only factor, but age is an important factor because your immune cells become senescent. It's called immunosenescence, or they become tired. And we need to introduce new immune cells. We need healthy immune cells. And that's what fortifying your immune system does, is it improves the function of your immune cells. So fortifying your immune system is really important regardless of your age, but it may bring may make you a healthy 65-year-old or a healthy 70-year-old. So you need to work on that for sure. And, Medicare is not the only risk factor. You could be 30 and you could have a chronic condition that's inflammatory based, or diabetes, for example, and you may be at high risk. So you really have to be thinking about those things as well. But I do think that anyone who can work from home should. I think that everybody who is at low risk. If they've assessed themselves to be at low risk, they should have a conversation with the healthcare provider before they go out, and they should think about still protecting themselves, because there's a lot of asymptomatic spreaders, and even though you don't have symptoms, you can still spread it to somebody in the vulnerable, medium, intermediate, or high risk group. And so it's really important to be cautious. And
Yeah.
masks are critical.
I think it brings us back to act as if. And so even though you're in the green, if you may be in the green, which is low risk and young and healthy, you're the ones that might be transmitting it to the people at higher risk. And look at what it says under high risk, under H. It says, if you're red, you're at high risk of continuing to work at that workplace. Consider stopping work, shelter in until one, a safe, effective treatment is found, and or a safe, effective vaccine is found, or herd immunity is obtained. Take all precautions, otherwise, facial covering, hand washing, and physical distancing.
This is the new normal, because in my humble opinion, it takes a long time to develop a safe, effective vaccine.
Yes.
And I know everybody wants to rush this, but we have to be cautious, as we are with hydroxychloroquine and remdesivir and all of the repurposed medications, because we need to understand the side effect profile of these vaccines and who they're best for and who shouldn't have that vaccine. So I think it's going to take a solid year to really know that we can roll out a vaccine, if not longer. So the only option we have is masks, physical distancing, washing your hands, and fortifying your immune system.
Absolutely. We had an occurrence today. Do you want to hear about it? Just got through with it. So we're doing, as our community knows, we're offering point of care antibody testing. And I think that we've educated everybody that you want to do it at least 14 days out from symptoms. And so we're doing our usual Friday point of care testing. We had a student who is in the healthcare professions come, and she had been sick in January. So she was the appropriate 14 days out to do point of care testing. And she really didn't feel sick in terms of fever or anything like that. But we did her antibody testing, and she had IgM positivity, meaning she's in the middle of it, without the IgG positivity, meaning it's gone. So if that is true, and remember what we taught you all, that it requires, the COVID diagnosis requires more than one testing. So if that is true, then those of us in the room who were with her were exposed. So we're going to take appropriate precautions. And, anybody who thinks they're exposed, you can go to the website, FIRRIMupDoctors.com, our website, and download the 14-day monitoring guide. So the team that was in the room with me actually are going to be working remotely next week. So we can monitor. And then she will have, I'm trying to get her to have quantitative antibody testing, meaning to measure the amount of IgM and to double check the IgG, because her real symptoms were January, February. But remember, because we're healthcare professions, our occupational risk is actually high just from what we do. She's in her 20s, so her risk of death if she were to have COVID is actually low. So so that it happens, we need to continue to act as if. So when we do antibody testing, we'll be able to circle back and tell you what if she's quantitatively positive. But this brings up the question that we had earlier, or the discussion, Dr. Kathleen, about pretest probability and prevalence, and what that means, how she could be actually a false positive. So can we pick up from that discussion we were having before we went on?
Sure. So what's fun about having a relationship with another doctor, like as close as Angela and I can be, is that we have conversations about what these things mean. So, and, it's nice to have different viewpoints. The question I would have would be, you typically are doing your point of care testing outdoors, and you're typically doing, how long does it take? I mean, to do this test, it takes only a minute to prick a finger and put the blood in the well, so where it has to go. So it shouldn't be a big exposure. So the couple of things about the antibody testing is that, about transmission. So let's pretend that this patient this healthcare provider, young, healthy healthcare provider, is asymptomatic and she's in the middle with an IgM of the infection, the likelihood of everybody getting infected is increased if the testing is indoors and if the time of exposure is significant. So that's important to understand. So a 5-minute exposure with 6 feet apart is probably not going to be enough time to transmit it unless she has a really big viral load. And the thought in the medical and scientific community is that there, maybe, I don't know, 1 in 10 or 2 in 10 people have a high enough viral load. So you're not going to come in contact with many people with really high viral load, except for the fact that she's a healthcare provider. So if you have 5 or 10 minutes with somebody, you're 6 feet apart. If you're outdoors, it's even better because most of the transmission, the silent transmission, happens indoors in small spaces where people are close together, less than 6 feet apart, and they're transmitted. But now what happens in a place like Gainesville or Alachua County, where there isn't a high prevalence, is that when you do testing, this is counterintuitive. This is not what you would think. But when you do testing in a low prevalence situation where a lot of people in the community do not have the bug, have not been infected, you can get false positives. So she could be a false positive. We have no idea. The key thing, the most important thing to understand about COVID-19 is you can never diagnose it with one test. You can get many false negatives with nasal swab. You can get many false positives if you have a low prevalence. If 50% of people or more, if you had herd immunity in Alachua County and you tested her, it's more likely to get a false negative, but it's possible she's a false positive. This test has to be confirmed with a quantitative antibody test. So, it's not useful to confirm it with another qualitative. It has to be confirmed within the next 7 to 10 days, not emergently, but within the next 7 to 10 days with a quantitative antibody test in order for you to really understand.
So it's interesting that I had her call her student services and they are planning on doing COVID swab testing on Monday. And then again, their protocol is to do it again 2 days later. What do you think of that protocol?
So the nasal swab?
Yeah, that's their protocol. And it turns out when I questioned her further, she said that she'd been having gastrointestinal symptoms for about a week, but she had assumed it was the spices she was eating. So as we taught before, 4 to 5% of COVID-19 infection could present with just GI symptoms or gastrointestinal symptoms. But in this particular situation, her school's protocol is to do nasopharyngeal swab on Monday and repeat 2 days after. We're trying to do quantitative antibody testing early next week for her.
Yeah, no. So in Boston, we did this. So we, in the healthcare system, in the hospitals, at the Brigham and Women, and at Mass General, what they initially were doing was you couldn't return to work. If you had a positive nasal swab for COVID, PCR, nasal swab testing, they would not allow you to return to work until you had 2 negative nasal swab tests in a row. And most people couldn't return to work. What would happen is they would test and you'd have a positive, a negative, a negative, a positive, and nobody could get 2 negative in a row because we've talked about this a lot. I've talked about this a lot on my webinars, that when you have viral PCR testing, you don't know if you're testing dead or a live bug. Live bug is infectious. Dead bug is not infectious. So if you take an ant and you cut it and you have a live ant and you measure it and it shows up positive, that live ant can make new live ants. So a live ant can make new live ants. If I cut that ant in half, don't be upset with me, I'm just an example. If I cut that ant in half and I have a head portion and a tail portion, the head portion alone cannot be infectious. The tail portion alone cannot be infectious. You need the whole bug to be infectious. So if you measure PCR, you're measuring all 3 of those. You're measuring the live bug, You're measuring the head portion and you're measuring the tail portion. And it's important to understand that you don't know, there's no way to know with a nasal swab which one you got. All you know is that you have a footprint of that bug. That's it. So it's not useful to continue to measure the nasal swabs. In fact, I think, 40% are negative and they really do have infection. So you can measure it when somebody has symptoms, but when they are asymptomatic, they no longer should we be measuring them to see if they have a PCR nasal swab positive. It doesn't make sense, or negative, because it could still be positive even though they're better, they're not infectious, and they are protected. So what they changed to do in Boston is they now started to do the quantitative testing. And of course, one of the major companies doing that is out of Boston. And so they went into the hospitals and they showed the difference with their quantitative testing versus the qualitative testing. And so pretty much there are two new guidelines in Boston. One is if you are symptom-free for 10 days, you can return to work, regardless of a nasal swab. So if you had symptoms or you had a positive nasal swab without symptoms, so you had symptoms of COVID, A, or B, you never had symptoms, but you had a positive nasal swab. 10 days from the positive nasal swab or 10 days without symptoms, you could return to work, or a quantitative antibody test. That's what they're doing in Boston.
And this is because you could have dead bug. You could just be picking up the RNA.
Correct.
Because way back in March, we were talking about those COVID positive swabs being up to 5 weeks after symptoms. And perhaps those were dead bugs 5 weeks into the process.
Yes, absolutely. I mean, it's really confusing. And I have to tell you, I'm disappointed that we're making this so confusing, that people really, I don't know if people are just like ants going around in a circle and following the mother ant, whoever's deciding this, but it really doesn't make sense. It's just not logical. So I do agree with doing nasal swab testing when randomly we can see if people have some PCR, but we have to follow up that testing. As we said, not one test can diagnose it. We have to follow up that testing with antibody testing. We have to determine if we think somebody has a PCR positive, within 10 days, 14 days, we need to see what their antibody level is. That's the responsible way to understand COVID-19. And that is really important.
Yeah, so I think after today's incident, and that statistic that only 0.3% of transmissions happen outdoors, we're going to, when I was analyzing after today's incident, it really emphasized three main points. When we first started talking, Dr. Kathleen, we had talked about acting as if you have infection, your neighbors have infection, and that they could potentially be transmissible to you. So number one, we need to act as if. Number two is our point of care testing. We're probably going to be moving back outside, even though it's really hot, because what ended up happening, at least in our building, we had been doing point of care testing in our small building called Ageless, where we were drawing blood, but I ended up having to call the viral mitigation people, Dryers DKI, which, by the way, if you have accidental exposure in your home or your workplace, Dryers DKI is so responsive. Like, they're coming to clean now with viral mitigation in that office. So the other thing is that now the team, the few people that were in the room with me when this happened, they're going to be monitoring for 14 days. So this has to do with workplace safety, and it's what we've been doing in consulting in our workplace. And it's really important to consider all these points when we go mobilize into the community. We never stop taking care of our patients, but every time we just try to get better and better in terms of safety. So we're happy to share this with our community. Next slide. So speaking of, I've been very busy in our community. Organically, people have wanted to have my opinion in maximizing workplace safety because we're in phase 2 and we were told to mobilize. So meet Christina Miller. She's the founder and owner and the head of Millhopper Montessori School on 39th Avenue. And she gave me written consent as well as verbal consent to discuss why she actually wanted help. She wanted to go ahead and open to a small number of students for camp. So I showed up at her workplace before everybody else at 7 a.m. and spent an hour going through all the protocols of drop off, pick up, and how to stagger that, how to have the children enter individually, the protocol for washing their hands. What if the children get sick? Then what? The playground. We basically spent time mapping out her summer camp. In addition, she and her team had previously decided to decrease the number of campers. And so we took a map and we just mapped out to make it as safe as possible in her school for both her team as well as the students, as well as the parents. And so she gave us a nice review. She said, I feel confident to open for summer camp and would highly recommend Workplace Safety Analysis by Dr. Akey. And this is really, really fun for me. I've had a very broad background in my medical training that included in medical school, I was in the United States Public Health Service, so I really like public health and prevention. And then during my residency at Yale New Haven Hospital, I actually did a rotation in occupational health. And in New Haven, Connecticut, there's a lot of factories. And one of the very famous doctors who developed the textbook in occupational health, I was privileged to rotate with him. So I was used to looking at outside of our four walls in our clinic. So I'm really having a lot of fun with workplace safety. So I'm going to put a shout out to this community. If you know of anybody, or if yourself, you're an owner or an administrator or someone on your team could use help in mobilizing your business back to a new normal, Dr. O'Neill Smith and I would be thrilled to help you either with individual consults that could involve on-site workplace ideas or virtual if you're far away. As Dr. O'Neill Smith said, she's managing 500-person company right now, and she's multi-state as well. So in our Gainesville community, I've consulted on 2 schools, a church, and potentially a resort of someone who owns elsewhere. So we've decided to go ahead and offer something because we've had all these requests. Next slide. We are starting the FIRRIMup Doctors Good Medicine COVID-19 Workplace Safety Masterclass. And so basically it would be a 3-month process where we meet on Tuesday nights for 30 minutes, 3 Tuesdays out of 4 for this month, July and August, so that would get you to help mobilize back into your facility. And we would be there to troubleshoot with you any new situations that come to help minimize risk to your team as well as your clients. We're limiting the class size to a very small class. So if you are interested, if you wouldn't mind having your friends or family or yourself email us at FIRRIMupDoctors.com, that's FIRRIM doctors.com, or call the office if you're local and you want some help. That master class is actually Zoom like this online, and it starts on June 16th. And again, it's Tuesday nights, 7:30 to 8 o'clock, three nights out of 4, 3 out of 4 Tuesdays per month, June, July, and August. In Gainesville, I think we're special in that we're looking at an influx of at least 40,000 students from around the country and around the world into our area, in which case there might be a second spike at that time, in which case we'll reevaluate. If y'all need more help on the masterclass, we'll continue it. But please consider the class. I think you'll enjoy it a great deal. And if you are interested, email it in, and me or myself or my team will call you and get you signed up for that Workplace Safety Masterclass, Zoom online, limited numbers of attendees. Next slide.
All right, I think it's time for some Q&A.
Great, perfect.
All right, for the questions that I have for today, the first one is, the CDC is now saying that surfaces are no longer a threat for others. Can we accept this guideline?
Well, you know, they just changed the site on their webpage of where they placed it. I think that you should still be cautious about surfaces and fomites, but it's not like they changed the level of concern. It was more that they changed the location of it on their website. But University of Alabama clearly published that there is some surface transmission. The question though I'd have now is, is it the live bug or the dead bug? Because what they are testing for is the RNA. I think I'm very conservative in terms of my opinions about things, and I would still continue to be careful and wipe things down as we're doing in our office.
Perfect. Dr. Kathleen, did you have anything to say on that one?
Better safe than sorry. Act as if, because this is not going away anytime soon.
Perfect. All right, our next question. Someone asked if it's safe to give blood right now.
Sure, why not? I start my video, perfect. Sure, why not? No reason not to give blood. If you've had COVID and you have antibodies, you could even give blood that they can use to treat patients who are hospitalized.
Yes, Life South in Gainesville is accepting people who have survived COVID well, and they're taking their plasma donations. So I've encouraged ours to donate.
Okay, next question. Is it possible that the virus will lose its potency the longer it is around?
Absolutely, but that's going to take a long time. That's what herd immunity is. So herd immunity is that this virus cannot infect people because there's not enough people that haven't been infected by it. And so that's when it loses its potency.
Yeah, it can't jump from person to person to person. So if you have a room of 10 people and 6 of them have antibodies, and they're protective antibodies, then it can't jump from person to person to person. So that's the concept of herd immunity.
And then going off of that question, someone asked if you know what will come first, herd immunity or a vaccine?
Well, Dio è maravilloso. Herd immunity would hopefully, come sooner because the vaccine is going to be some time, and that we can be pretty much guaranteed of. And the other thing about the vaccine is that, again, anything that you have to inject, unlike convalescent serology, can have side effects. So we want to reduce side effects. So if we could get herd immunity safely, optimizing and fortifying our immune systems and getting some immunity like my patients have had, not one patient being hospitalized, but, developing these antibodies and being protected, I would say that that's the ideal situation. So I hope that that happens first, but I'm not confident that that's going to happen quickly.
Dr. Akey, anything that you have to say on that one?
No, I agree. I agree with them. Yeah. And we don't have much penetration and or prevalence, at least in our community at this point. And I think that's because we've been so careful. And like I said, for the low risk people to go out and serve the community, because somehow we have to develop herd immunity, not to be careless, not to congregate without masks, but it's the young people that are healthy that will have to help us develop the herd immunity sooner.
And someone just asked in the chat based on that today Dr. Fauci said there will be a vaccine available by beginning of 2021. Do you agree with that?
Well, that's 6 months from now. I think that's pretty ambitious. That's my humble opinion. I love Dr. Fauci, so I don't want to, I don't want to object to what he said, but we'll see. I mean, and if the vaccine is around, is it really going to be optimal? I mean, you all know how hard it can take 2 to 15 years to make a vaccine, 2 to 15 years. We don't even have a vaccine for the novel virus HIV because it requires a cocktail, because there's so many different mechanisms. That's why you've heard about hydroxychloroquine and remdesivir and the monoclonal antibody treatment. There are so many different treatments that we utilize in trying to attack this virus once it infects somebody who gets sick with it and needs hospitalization. So it requires a cocktail of medications. If a bug requires a cocktail of medications and is complex and is novel, I don't know. My humble opinion is that in 7 months or 8 months, early 2021 could mean March. We've got 9 months away. Are we really going to have a vaccine? They've been working on it. That will be 1 year from now, 1 year from the beginning, from the onslaught when people started working on it. It's possible, but I'm not certain that that's the solution because of, other issues with respect to adverse effects. It will be good for some. If it were me, I'd rather have convalescent serology.
I agree.
Another question based on the herd immunity is about all the protests going on around the country. Do you think that is going to be something that will spark herd immunity, or no, since it's outdoors and people are wearing masks?
Well, I think it will definitely spark herd immunity. We'll have to wait and see. We have another 2 weeks or so to see what happens. But I think that that would be good if it sparked herd immunity. I think outdoors you can, there's not a lot of data that suggests that outdoors is the main way, but these people are close. They are in close contact, and they are in close contact for hours, and they're yelling and they're screaming and they're hugging. It's very likely, even though it's outdoors, given the nature of the closeness of their contact and the likely respiratory droplets that are being exuded, it's likely that we get herd immunity from that. It is likely that there is a significant uptick from that.
All right, we have a few more. This one's a little bit longer, but there's a backstory. It says, a friend just sent me this Washington Post article about how some people have been sick with coronavirus for more than 60 days, and it sounds a lot like my situation. I was actively sick for 5 to 6 weeks, and now I feel like my lungs are starting to decline some, and I'm having to rest while trying to do some stuff around the house. I was wondering if you could speak on this.
You definitely need an evaluation. I don't know if you've been tested, but you need an evaluation for multiple things. And I think it's pretty urgent, not emergent, but you need an evaluation. And if your lung function is going down, if your oxygen status we've talked about is going down, you need an evaluation emergently.
Yeah, that's a prolonged time. If you're one of ours, the NFIM GMV hotline is still going. I would do a telehealth on you within 2 hours. So if you're one of ours, the NFIM hotline is nfimgmv@gmail.com. That's the abbreviation for North Florida Integrative Medicine Gators Make Victory @gmail.com. So our hotline's still going. But I agree, you need an evaluation. That's a long time to be sick.
You need a full evaluation, not just for COVID, but you need an evaluation to understand what's going on, because that is a very long time. That's not the typical time course of COVID. It can happen, of course. So it's got to be ruled in or ruled out along with other things.
All right, let's see.
Oh, okay. So I'm reading the chat. Okay, it's patient 0. We know patient 0. Patient 0 still has lung residual. So patient 0 came back from Italy, was diagnosed with respiratory syncytial virus. COVID wasn't diagnosed till retrospectively, the retrospectoscope with an antibody test. And so her lungs have been damaged, and that's what she's saying. So we still need to get her into a pulmonologist. So I doubt it's chronic COVID. It's residual 2 bad viruses on your lungs that have damaged your lungs. Hopefully not permanently, patient 0.
Everything can be changed. You just have to do the hard work to do it.
All right, I think we have time for 2 more questions. The first one is about the second wave that seems to be starting. People are wondering if you think they will put us back in a quarantine once they start to see numbers pop up again, or if they'll leave it at what it is.
Well, in Boston, we're going to go back into quarantine undoubtedly, because as soon as they see, again, where the numbers are with relation to a curve, are the numbers going on the upside of the curve or on the downside of the curve? The numbers are the numbers, and you can always compare them with prior numbers. If there's an uptick, we are going backwards. And we're pretty provincial here, and we're pretty conservative here, believe it or not, with respect to healthcare. So, and with respect to the number of beds that are available, we only have so many beds available. We would definitely go back into quarantine. And here, if you go out without a mask, you get a fine. You cannot, in most communities in the Boston area, where the hospitals are, Brookline and Cambridge, where Harvard is, if you walk out your door or a child walks out the door without a mask and somebody, sees them, they will get a fine, several $100s.
And I think that's what would happen too in town, is if if we see an uptick, then we're going to stop and evaluate and see what happens. But I think we're all trying to be careful together, trying to mobilize, but also assess and reevaluate along the way. At least that's what I've observed in North Central Florida. I see a question here that I want to address. There was, it's from Lisa B. There was a news report from the WHO this week that was confusing. It said silent transmission of COVID was not really happening. What is the truth? So I just wanted to go back to our initial paper for today from June 3rd of Annals of Internal Medicine, the prevalence of asymptomatic SARS-CoV-2, the virus infection. And basically it was an analysis from several cohorts of populations that came up with the bottom line that asymptomatic persons seem to account for approximately 40 to 45% of SARS-CoV-2 infections, and they can transmit the virus to others for an extended period, perhaps longer than 14 days. But if you look at the paper, it was a good paper because it looked at multiple cohorts. It looked at cohorts in Iceland, in Vo, Italy, the Diamond Princess Cruise Line, the Boston Homeless Shelter, the Los Angeles Homeless Shelter, and the New York City obstetric patients, and the USS Theodore Roosevelt, the Charles de Gaulle aircraft carrier, Japanese citizens evacuated from Wuhan, Greek citizens evacuated from Spain, Turkey, and United Kingdom, nursing facilities in Washington, inmates in Arkansas, Rutgers University students, Indiana residents, and the list goes on and on. So I'm not sure where they got that, but I do believe this is a very good paper that we were quoting from June 3rd.
I think the reality with that is it is so confusing, and there's so much information, and we don't even understand the agendas of whoever's providing the information, regardless of, your bias. The reality is that we don't have the data. We don't even know what the testing means. Confirmed cases, confirmed by what? So again, back to Dr. Akey should run the show. She has a standard operating procedure. And we need a standard operating procedure. And we don't have a standard operating procedure. We don't even know when people report data, nobody specifies what type of testing they're talking about or whether the testing was done when the patient is symptomatic. And honestly, it's a disgrace because in order to interpret data, you need to understand how the data was obtained. And if we don't and all scientists should know that. This is not rocket science. This is basic, common sense. There's nothing special about it. And the fact that we don't have that makes it difficult to make these judgments. We cannot make judgments without understanding how the data was obtained. So I would say it's logical that there can be asymptomatic transition. It makes sense if somebody has an amazingly fortified immune system, that they may carry it, they may be a carrier, and they may not get infected. How much of the population is doing that? What's the percentage? What's the prevalence? We have no idea. We just have to act as if.
100%, especially after today, Dr. Kathleen.
Mm-hmm.
All right, well, it looks like we are out of time for today. If you have any further questions, you can email it to our FIRRIMUPdoctors@gmail.com on the screen. And we're gonna go ahead and say bye to Dr. Akey and Dr. Kathleen for today.
Bye, everybody. Thank you all for coming.
You're the best. Thanks for coming. See you next week.
Thank you, guys. All right, and just to wrap up, once again, this is our guidebook, Kick COVID-19 to the Curb. You can get it on our website, FIRRIMUPdoctors.com, along with our ebook. Again, our June special for the month, if you buy our Kick COVID-19 to the Curb, either ebook or paperback, you will get 20% off of the following supplements: ultra potent vitamin C, zinc, PRP spray, and olive defense. And again, if you have any further questions, you can always email us at FIRRIMUPdoctors@gmail.com. And after we finish today, we're going to head over to Facebook and answer any questions. If you want to pop over there and send a question in the chat or a message, we will go ahead and try and answer that as quickly as possible. Thank you guys for joining us, and we will see you next Friday.
We're so glad you joined us today.
We hope we've given you the tools to take control of your health.
For more good medicine and information about any treatments, supplements, and resources discussed today, please visit us at www.FIRRIMUPdoctors.com. That's FIRRIMUPdoctors.com. FIRRIMup.doctors.com.
And wherever you're listening from, remember to like us on Facebook and subscribe to our YouTube and podcast channels so you don't miss out. The information provided is not a substitute for professional medical advice. This should not be used to diagnose, treat, or manage health problems without consultation. If you do experience any of the symptoms discussed today, please contact your nearest healthcare professional.